Thank you so much. It's so wonderful to be here. I really want to thank Kim and Megan Castle and the Women's Health Research Institute, as well as the Hollister Fund for allowing me to come and share some of this work and have this conversation with you guys. And it's so great to see such a large turnout kind of to talk about kind of a sobering topic, but a really important one. It has been probably about a year or so since the images across the television with regard to this particular couple aired, really generating a lot of public discussion with regard to the whole topic of domestic violence or intimate partner violence. And in some cases, what the fallout has been is really sort of generating a conversation, more of a public discussion and conversation and awareness about intimate partner violence. In some cases, unfortunately, the conversations may be a little slanted and perhaps a bit misleading and not necessarily well informed. And in other cases, the conversation has been a bit more informed and more enlightened. And so what I'm hoping to do is also sort of add to the more enlightened side of things with regard to the discussion on intimate partner violence. Let me start with a definition, because there's a lot of different terms out there. Domestic violence is probably the term that everyone uses the most commonly. But the tricky part when we talk about it in research is that people had different definitions of what constituted domestic. You know, did it mean that it was just all violence that occurred within a domicile? Then does that include elder abuse? Does that include child abuse? If we really look at it as just being spouse abuse, then are we just limited it to people who are married? If it's wife battery or dating violence, all of these different terms kind of were tossed around, and nobody really had a really good idea about what people were really talking about. Until 1999, the Centers for Disease Control gathered together various different researchers and experts and advocates in the field to try to form some uniform definitions. And this is what they came up with. This is the definition of intimate partner violence. They describe the intimate partner as current and former spouses, dating partners, and this could include opposite sex partners and same sex partners. So essentially it's any sort of sexual or intimate or romantic partner. Violence, they had sort of a broad definition of violence. It was certainly physical violence, sexual violence, but also included threats of physical and sexual violence. And it also included psychological and emotional abuse. Since then, with more understanding about other types of intimidation, violence, and abuse, including stalking and cyber stalking, those have also been added to the definition as well. So the really sobering thing, I think sometimes when we sort of see what had happened with that particular couple, you know, if we are so fortunate to really not have this touch us at first, you feel like it's such a rare sort of thing, that it really is just a small isolated group of people that it's affecting. But the reality is actually quite different. 1 in 3 women in the United States have had a lifetime history of either physical or sexual violence from an intimate partner. This was a survey that had been done by the National Institutes of Justice and the Centers for Disease Control. But in any case, 1 in 3 had ever experienced any type of physical and sexual violence. 1 in 4 women in this national survey of women had experienced what they constituted or kind of designated as severe physical violence. And let me tell you a little bit of what constituted severe physical violence. Being beaten, hit with something hard, choked or suffocated, burned, slammed against something, stabbed or attacked with a weapon, including a gun. So 1 in 4 women, 25%. Between 30 to 60% of women who are murdered, and this is sort of the average across all of the states actually is about 30%. Between 30 to 60% of women who are murdered by either a current or former intimate partner. And it's certainly outside of sort of the mortality and situation, it definitely has some morbidity associated with it. We know that it's associated with sexual health. About 40 to 68% of women in IPV situations are also sexually assaulted by their abusive partners. And women who experience IPV describe feeling unable to refuse sex with partners and difficult negotiating condom use. It's associated with sexually transmitted infections. In one study, they looked at sort of the association and found that if there was one episode of IPV, the woman was twice as likely to have had a chlamydia infection. However, if she reported 4 episodes of IPV, she was 5 times as likely of having chlamydia. In a separate study looking at association between IPV and HIV, they discovered that about 11.8% of cases of HIV among women in the United States were attributable to being in an IPV situation. We also see that it's associated with unintended pregnancy. Women with unwanted pregnancy are 4 times more likely to have experienced physical IPV and 2.5 times more likely to then experience physical violence around the time of pregnancy. And in terms of IP and abortion, there's been several studies that consistently show that about 30 to 39.5% of women seeking abortion reported having a history of either physical or sexual abuse from a current or former intimate partner. And another sort of study that Dr. Gee and colleagues sort of did found that successive unwanted pregnancy was associated with 11% greater odds of IPV. And each additional abortion was associated with a 16% greater odds of IPV. The other thing, too, that was interesting was that the decisions to seek abortion was more likely to be without the partner's knowledge or agreement when a woman was an IPV victim than in cases without IPV. So something to kind of think about. Recently, actually, within the last 5 years, we started to get a better understanding of another phenomenon that's associated with intimate partner violence, and that's something called reproductive coercion. Reproductive coercion can be split into 2 different sort of components. One is pregnancy coercion, and what that is any male partner's attempts to promote pregnancy, either through verbal pressure or threats to get their partner pregnant. The other component of reproductive coercion is birth control sabotage, and that's direct interference with contraception. So either preventing a woman from actually going to be able to go to her visit to obtain contraception, or somehow interfering with that contraception, taking off the condom, putting holes in the diaphragm, flushing the pills down the toilet, or even some incidences where they actually removed IUDs. In one study that Miller and her colleagues did that actually looked at the coastal sort of sites, California as well as sort of Massachusetts, they were doing sort of a large study of more than 1,700 young women who were seeking care and family planning and reproductive health centers. And among that population, and these were 19 through 30 to 29-year-olds, among that population, 50% of them had a baseline history of having experienced either physical or sexual intimate partner violence, so a higher proportion than what we've seen in some of the other statistics. But among that population too, 19% described experiencing pregnancy coercion, and 15% described experiencing birth control sabotage. Of those who reported reproductive coercion, between 36 to 79% actually also described physical and sexual IPV. So this appeared to be sort of something that existed hand in glove with the experience of physical and sexual IPV. That study did not actually specifically look at emotional or psychological intimate partner violence, and potentially then, if they had, a greater proportion of the people who experienced the reproductive coercion may truly have been victims of other forms of IPV. One of the things that this makes us sort of concerned about is, what do we do? What is the issue? Why do people stay? Why do people stay in these sort of situations? Why can't she just leave is the big question that sometimes pops into our heads. If the relationship's toxic, it seems very clear you just need to kind of leave. However, it may not be safe to leave. And when we look at some of the homicide studies, about 50% of IPV-related homicides seem to occur after a separation event. So the woman may have tried to leave. She may have broken up with that person, kicked that person out, moved out herself, filed for divorce. And another study in which they actually did, this was Judy McFarland's multi-site study, they actually went, and Jacqueline Campbell's multi-site study, they went and actually interviewed people who had survived what was meant to be a lethal attack on them, or they interviewed trusted proxies of people who had been murdered by an intimate partner. And they wanted to kind of determine what were some of the factors that actually increased the chance of victims of domestic violence or intimate partner violence being killed by an intimate partner. And one of them was leaving. The odds of experiencing a lethal attack from a perpetrator, it was more than twice the odds if the victim was trying to leave. If the perpetrator perceived that she was trying to leave for another relationship, those odds were even higher, something like 4 times the odds. Even if it weren't true, even if she weren't leaving for somebody else. So all of these sort of statistics and all of these associations really, leave us with a lot of different emotions. Certainly there's fear and confusion, doubt. We wonder sort of how we can actually address such a big, complicated problem. But hopefully we can still have that hope and wonder in terms of actually realizing that we can make a difference. And that was some of the work that my group had started to look into by wondering sort of a little bit more about what was going on with the women, what did they want, and what did they need. I think it actually revealed some findings that gives us some hope that we, as healthcare providers, as researchers, as citizens that want to actually help other people, can make a difference. So one of the studies that we actually did was understanding the process of change, because if we don't really understand sort of what women go through, we can't really truly understand where and how we can help. So one of the things that we wanted to do is ask women, what has been sort of their process of change? Can they walk through and tell us what their story is and where they try to do something different to make a difference, and what influenced any sort of positive changes that they experienced. We conducted 20 semi-structured interviews with women who either were in a current sort of intimate partner violence experience or had been in one in the past, and the women described their stories. We used an analytic approach and coded using a very inductive, open-ended sort of approach. And from this, what we created was sort of a model that we called the readiness model. We discovered that there were both internal factors that were inherent to sort of a woman's own psyche and situation, and that there were external factors that seemed to influence whether a woman were moving towards changes that would take her more towards safety. So looking at the internal factors, the 3 key components that seemed to be important were awareness. Awareness that the intimate partner violence was not okay, that this was not natural, this was not healthy, this was not deserved. They did not deserve this. And the awareness was also that there were options, that this was not what they had to feel trapped to being in. The other component was a sense of self-efficacy or power, that there was something that they could do to make themselves a bit more safe. And the other was perceived support, that they were not alone, that there were others out there that could help them. When you had all 3 of these, it seemed to be what would lead people towards sort of changes that would make them safer. Sometimes there would be one without the other, and what we notice is that it may not necessarily then lead to as much change. You might have awareness that she feels that there is this issue and that she knows that this is a problem, but if she doesn't feel like there's anything she can do or feels like she's completely alone, she still might stay in that same place and feel like there's nothing that she can, there's no sort of hope. There might be perceived support where there's a lot of people who are trying to help her, trying to advocate for her, trying to offer different sort of resources and things. But if she's not really even gotten to the point where she's acknowledged that this is a problem, where she feels that this is something that needs to change, or that she doesn't deserve this in some form or fashion, she may not then be receptive to all of that help that's offered. In terms of the external factors, we saw that there were both internal or interpersonal as well as situational factors that would influence that movement back and forth. And these were things that can sometimes facilitate readiness or a movement towards change and towards safety, but also there were those that would hinder readiness as well. The external factors that would hinder readiness were, for example, the interpersonals, that these were other people who might be placing barriers, or others' attempts to provide positive support, but that this support was not terribly helpful or not perceived as helpful. And I'll give some examples on what that is like. Or they're situational. There might be negative factors in the external environment. The worry about not having housing, the worry about being dependent on their perpetrator for financial support and not knowing where that financial support would come if they were to try to leave, not having employment or a job. And so these would be some of the components that would kind of keep people from moving forward towards safety. These are some of the quotes from some of the women in terms of demonstrating some of those external factors that were barriers. So he hits me upside the head, but my rent is paid and my refrigerator's full of food and I have credit. And if I just don't irritate him, then maybe the violence won't happen. Another quote, I was told that they didn't believe me, including by people that I really liked and trusted. And another, and this is an example of when someone was trying to be really helpful, but maybe didn't do it in a way that was perceived as helpful. And instead of it being between me and him, he, my doctor, said something in front of my partner and ended up making it worse. There are, however, external factors that then can facilitate readiness. Support from others that is perceived as helpful, or positive changes in the external environment, such as alternative housing, other sources of funding, and employment. And all of these could be things that would move people towards safety and towards change. Some examples. She said to me one day, and the she actually refers to one of the nurse practitioners. She said to me one day, did you ever stop and realize that you have the right to decide what's acceptable and what isn't? And that planted a seed in me. I didn't leave then, maybe 4 or 5 years later. And ever after that, every time he acted strange, I'd think, this isn't acceptable. So she really planted the seed. It took a long time for me to act, but she more than helped. He, and this actually refers to a male resident physician, he sat there and he looked at me. And the look in his eyes, like he was really interested and wanted to hear what I said. He didn't just play act on it. He actually heard what I said and listened to me and kept that eye contact. So this was our final model with regard to sort of the readiness towards change and towards safety. And how can then we as healthcare providers help? Most healthcare organizations have had different sort of policies and recommendations and guidelines that advocate that healthcare providers need to be asking or screening all patients, or especially all female patients, for intimate partner violence. Many of the studies that had been done asking women, because one of the original concerns was, oh, well, maybe women will be offended if we started to ask them about this, or maybe they don't like this if we're prying into sort of their personal business. And so a lot of surveys had been conducted, and every single one of them really found sort of that the women wanted providers to ask and offer information about intimate partner violence. Then in fact, they viewed that this was the healthcare provider's responsibility and role. But as we think about sort of the whole concept of just screening and asking, one of the things that we have to sit back, though, is to think, well, what is the point about asking? What are we really focusing on? Are we focusing on making a diagnosis? Are we really wanting to kind of expand awareness? Do we want to trigger a dialogue from this? Because all of these things, in terms of trying to figure out exactly why it is that we're asking, actually has implications on sort of how we respond and how we treat it, and also how we actually ask. So that's another study that we actually conducted. We wanted to find out when healthcare providers ask about intimate partner violence, what actually happens as a result of it from the perspective of women, and what advice would they give to us for how we should be talking and asking about this topic. This was another qualitative study. This one was a focus group study. And we conducted 7 focus groups. 5 were with the English-speaking women, and 2 were Spanish-speaking women. 5 were conducted in Pennsylvania, and 2 were in North Carolina. Oh, I'm sorry, flip side. 5 were in North Carolina, and 2 were in Pennsylvania. And we asked two main research questions. One was, what happened when a doctor or nurse asked you about violence in your life, specifically focusing on domestic violence or intimate partner violence? And then what advice would you give doctors and nurses about asking and talking about domestic violence? And so what we heard from them was that there were some positive consequences that they had noted and had experienced. And these were the three main themes that emerged from those positive consequences. One, just by asking, just by us bringing it up, they then realized that IPV was a problem. They also felt that when we brought it up, that then there was a decreased sense of isolation, particularly if they had the opportunity to disclose or talk about it. And then the third is that they would oftentimes then feel that the provider actually cares about them, cares about what's going on in their lives, and cares about what's going on in their relationships. Here are some of the quotes from some of these focus groups. I needed somebody to make me see, to remove the blindfold over my eyes. I felt pretty good that somebody was concerned about me, about my life, about my baby. And just with a simple, caring word, you feel that you really are worthwhile, that they care about you, that somebody else cares about our situation. However, they did sometimes describe some negative consequences actually related to our screening. In some circumstances, they actually felt that the questions made them feel judged by the provider. In other cases, they felt disappointed in the provider's inadequate response to their disclosure. So they took this as an opportunity to disclose, but then were disappointed in the provider's response. So it's not just about us asking. We also need to know sort of what to say when they disclose. It's the way they're asking. Sometimes a lot of doctors are really condescending to people. She had told her family physician, and then he said, I don't have time to talk about that right now. In terms of the advice that they gave, and how we can do this better, how can we actually be bringing this topic up to them in a way that is more receptive, safer, and more comfortable? So they gave these bits of advice. One is to give a reason for asking. They described that sometimes they weren't exactly sure why we were asking. Was this just sort of us being nosy, or in Pittsburgh, the term is nebby, so you've just learned a little bit of Pittsburghese. Were they just being nebby or nosy? Were they just clicking off sort of check boxes for their forms, or was there some sort of ulterior motive? Were they going to take their baby or children away? Were they going to call immigration or the police on them? Were they going to get people involved that they didn't want? So all of these things would be questions that would sort of race through their brains. And so they said, don't have us wonder. Tell us why you're asking. Give us that reason. Don't just be asking to ask for your own sake. Ask because you're there to offer help. And they described that, if it's part of screening, then just say so. I ask everybody. This is so important. This is affecting so many people. And this is why I want to talk about it. Or even if you actually are suspicious, there are things that are making you concerned and worried about her, then tell her that you're worried about her. These are some of the things that I see that make me really worried about what might be going on at home, because I've seen this with other patients who've had situations of intimate partner violence, and I'm worried that that's what's happening with you. So tell her why you're asking. To create a safe and supportive environment. That if the environment itself is welcoming, that actually makes them feel more comfortable. Use non-judgmental tones and words. So, for example, if you use something like, you don't let anybody hit on you, do you? That makes them feel very uncomfortable when they have to say yes, and they're going to be likely not to say yes. Even the phrases or the terms of victim and domestic violence may be misunderstood or felt to be stigmatizing. And so by focusing more on the behaviors in the situation rather than on them or the labels, that might be helpful as well. Speaking with the woman alone was something that they also described in terms of creating the safe and supportive environment, because they actually described situations in which they were asked about intimate partner violence when there's someone else in the room, including their partners. In fact, As a reminder, two of these were done in Spanish-speaking groups, and many of the women described that the translators that had been used were their husbands. And so when they were asked about intimate partner violence, they said that their husbands naturally answered for them and said, oh, no, not at all. And so they definitely said that they needed to have these conversations when they're alone. They also said to make resources available regardless of disclosure. They talked quite a lot about how difficult it sometimes is to disclose. And you could be the nicest person that they've ever met, and you can say all the right words and have the right environment, yet they themselves may not be quite ready to actually say it out loud or even label it for what it is or tell anybody. As this quote describes, you want them to know the truth, but you're too scared to tell them. So you want them to read your mind, but they can't. So they wanted all of us to recognize that it may be difficult for them to disclose and to understand and forgive them for that, but to still offer resources and information and support regardless of their disclosure. If it's freely available and posters on the walls, brochures that they're able to take without having to seek anybody's permission, tear-off tags in the bathrooms, any types of things that are sort of freely available, then they can take it if they feel comfortable. And then they have something for when they feel ready to use it. They also wanted us to respect their autonomy, to ask her what she wants and needs, and to not give direct advice. They talked about how many times many people were telling them what to do, including the perpetrator, and that this was confusing and disempowering, and that it really, really was important for us to make sure that she's the one who gets to decide. Quite honestly, we don't know the full context about everything that's going on, and she's the only one who knows that context. And so even though it may not make sense to us, it may make complete sense to her with all of the different things that we don't know about, that she hasn't been willing or able or brave enough to kind of share with us, to actually make those decisions. And so it may not make sense to us, but it's whatever makes most sense to her that we need to respect. This was one of the quotes with regarding respecting autonomy. Nothing came from me because everyone told me what I should do. I don't know what I should have said then if someone had asked what I wanted to do. I probably would have said, I do not want a divorce right now because I did not at the time. But I wouldn't want for one because everyone said I should, and I still regret it. Even if it was the right thing, I regret it because I did not do what I wanted. I did what everyone else wanted me to do. So we also started looking exactly at the communication. So these are the things that the women told us that they wanted to hear, and they told us sort of what happened when they did have some of these conversations. And so one of our questions was, well, how are these conversations happening, and how are they impacting the women? And so that was our next study, was to actually look at that. And we wanted to look at the communication that was occurring, and particularly in the first OB visits. The reason why we chose the first OB visits is because at our institution, we knew that over 90% of the OB providers were actually asking about intimate partner violence during that first OB visit. And so this was going to be an opportunity for at least us to capture sort of those conversations. This was in contrast to other sort of visits, especially even return OB visits, where the questions seemed to fall off, and less than 20% sort of seemed to happen in the return OB visits. In ER visits, Dr. Karen Rhodes and her colleagues looked at ER visits and had noticed a very small proportion of those conversations having these discussions. And so we knew from our chart reviews that at least these conversations are happening in that particular visit, and that's why we chose it. We also realized, too, that it was probably a window of opportunity for some counseling and some change, and so we were very hopeful that this was going to be something that we would see. So our two main questions were, we wanted to describe how the obstetric care providers asked the patients about intimate partner violence during that first OB visit, and we wanted to get a sense on were there ways that they asked, things that they used, words that they said that seemed to be a little bit more associated with in-person patient disclosure of intimate partner violence. In terms of our methods, what we ended up doing is we audio recorded first obstetric visits for all people who were presenting for first OB visits in our clinic. We chose this because it's the most thorough visit, and as we noted from the chart reviews, because this was when the providers asked. The subjects also completed a computerized questionnaire immediately before meeting the provider. And on that computerized questionnaire, we had 2 questions each that asked about past and current physical, sexual, and psychological/emotional intimate partner violence. These are the dates in which we collected that data. Our data then included all the audio recorded conversations, and what we then did was that we coded these to look for when the providers asked about intimate partner violence and when patients actually disclosed. The provider IPV inquiry is coded as being direct, meaning that it was specifically about violence, that it wasn't going to be something that would be misunderstood. So they either used the phrase domestic violence, or they described sort of being physically hurt, or gave other definitions of sexual violence, physical violence, or emotional violence. We also coded them as indirect if it was a little bit more nebulous. Things like, are you safe at home? Or how are things with your partner? Or how are things at home? Or how's the marriage going? Those would be a little bit more indirect. Or there was none. And we also wanted to see, just like what the women were saying before, since they had advised giving a reason for asking, were the providers actually doing that? And then we did bivariate analysis to look at the associations between IPV inquiry communication and disclosure. When we were listening to the styles or communication styles, we did seem to pick up that there were 2 distinct different sort of styles. And we looked in the literature of communication analyses and found that there had been some description of these different types of styles. One was more of an information exchange type of style, question asked, question answered. And this was labeled as transactional. The other was interactional, meaning that it was focusing on rapport building and interpersonal relationships. So there was a little bit more of a warmth there, a little bit more sort of engagement in terms of actually getting to know each other as people. And then we created a third category because we actually sort of perceived that there was something in between, which was transactional social talk, meaning that was mostly information exchange, question asked, question answered, but that there would be some social talk sort of thrown in there, some joking, comments on the weather, compliments on person's socks, different things like that. And so when we looked at the data, we noted that just like our chart review, 97.6% of our 244 visits had the providers asked about intimate partner violence. About 247 of the subjects actually completed the questionnaire. We had some technical difficulties, and that's why some of them sort of dropped out there. And out of 250 patients, there was 27% that disclosed IPV to their obstetric care provider. Out of the 247 who completed the computerized questionnaire, there were 34% that disclosed IPV. There were, interestingly, 4 patients who actually self-disclosed prior to their provider actually asking as well. So in terms of some of our results, we found that disclosure was not actually associated with direct language or providing a reason for asking. And the other thing that we also ended up coding for was repeated questions, because sometimes people would actually ask multiple times. And so we wondered what that would do. And none of this seemed to be associated with disclosure. In truth, though, the reason for asking actually didn't happen very often. But the direct language did. Most often, the question was, have you been a victim of domestic violence? Among the 24 patients who disclosed IPV on the computer, but not in person, 22 actually described experiencing psychological IPV, and 9 were only positive, or only described psychological IPV. And so certainly if the question were asked focusing specifically on physical IPV only, or even in the context of just asking, have you been a victim of domestic violence, but having the patient interpret that only in the context of physical violence, then that could have missed these 22 people. Looking at the communication style, though, this was interesting to us because in visits where the provider used an interactional style, there was a 74% higher odds that the patient would disclose intimate partner violence. And so if we actually created a safer environment where we really sort of used the style that indicated that we wanted to get to know the person as a person, it seemed to make them feel a little bit more comfortable disclosing. Other researchers have noticed then that we can help people. And my friend and colleague Liz Miller and her group actually did a study that noted that we can actually help without requiring women to disclose. So going back to some of their suggestions about providing resources and information and support without requiring disclosure, that is one of the things that her group sort of tested. They did a randomized controlled trial in those family planning clinics that I described to you before for reproductive coercion. They did a randomized controlled trial where they basically actually provided preemptively information about intimate partner violence. They gave brochures, they gave sort of cards, they told them, we wanted to let everybody know about this because this affects people's health and safety, and we want to make sure that people have the resources that they need. In that RCT, women who received the intervention, both those who did and did not experience IPV at the baseline sort of survey, were 63% more likely to end a relationship at 12 months because they perceived the relationship to be unhealthy or unsafe. So there was a positive impact, even among those who did not describe experiencing IPV at baseline. There was a positive impact of having this preemptive awareness or educational sort of intervention without requiring disclosure. And so when we look at the overall model and sort of how we can actually help women, we can see that how we actually interact with them, the conversations and communication that we have, could actually deal with these three sort of things. We can increase awareness. We can just provide to everybody the National Domestic Violence Hotline number, even if they don't feel comfortable taking a brochure, or even if we don't have the posters and pamphlets up in our waiting rooms, we can let everybody know that there is a 1-800-799-SAFE number that is 24/7, answered by advocates that are trained to deal with anyone who's experiencing domestic violence in all of the states. So this basically allows them to call them, get some immediate crisis counseling and safety planning, but then also be linked to all of the resources that might be in their area. So rather than us having to sort of memorize and know all of the different sort of resources that might be in our specific areas, the folks who actually work on this hotline, that's their job. So they know sort of all of the different regional and community resources and can link them to them. We can provide empowerment. One of the things that the women talked about is that if we give them space to actually talk, that they feel empowered just by telling us their stories. When you start to talk, to tell them, healthcare providers, what you're really going through in your life, they, the abusers, they start to lose the control that they have over you. One of the things that they described was that sometimes what was being used against them was the threat of the secrecy was a part of sort of the way that the provider or the perpetrator ended up controlling them. And that by breaking that silence and eliminating that secrecy and finding advocacy within us, they felt like they were taking back some control. In terms of other forms of empowerment, we can have discussions on sort of asking them, what would make you feel more empowered? What would make you feel safer? And we can brainstorm and strategize on plans for safety. The advocacy community creates something that they call safety plans, because their approach when they answer the hotlines is that they don't want to give directive counseling. They want to make sure that, they help by empowering the woman to come up with some of her own strategies, things that actually work for her, things that she feels comfortable with. And so it's much more counseling about sort of what would work for you, or what do you think you would find helpful. And those would be safety plans. They would, though, however, sometimes suggest that these are some things that other people have found helpful, and they might sort of suggest some of those things. So these would be the questions that we might want to ask. What things can you do to help keep you safe if the violence starts up again? Several studies have looked at when people actually have the discussions with regard to safety promoting behaviors or safety plans, women will actually increase the number of safety behaviors that they actually do. And these are some of them. Hiding money, opening up a credit card, hiding extra set of car keys and cab vouchers, a bus or subway passes, keeping a copy of crucial ID, such as their driver's license, social security card, passports, and birth certificates, so that if they do have to leave, it could be on the cloud or at the work or some other place, so that if they do have to leave and start over, that they have some way of identifying who they are so that they can access other things that require that identification, like their finances and their health information. Keeping a copy of the children's records so that if they need to re-enroll the children in another school or bring them to another location. Setting up codes with trusted families or friends and asking neighbors to be alert to signs of violence. Keeping track of medications, bank numbers, and insurance numbers. Having bags with clothes, toys, and toiletries sort of hidden and easily grabbed if they needed to make a quick escape. And identifying safer areas in their environment. Sort of like when we get on the plane and the flight attendants tell us to pay attention to where the nearest exits are to us, one of the things that they can think about is what are the places in their house or their area that's safer, so that when they get a sense that the violence might be imminent or escalating, that they can move to those locations. So instead of being trapped in the kitchen where there's multiple things that can be used against them, or the garage, or in the bathroom that is tiny and has no window and no door to other places, they can maneuver themselves into a room that has access to the outside, that they can lock the perpetrator out of, that they have good cell phone reception or a telephone line in. And so these would be things that you can help them brainstorm about. And certainly we can offer support. As one of them said, it helps us to believe in ourselves. People respect doctors. And when a doctor says something, you know that looks better on you, that somebody that's professional would actually believe in you. And these are some of the phrases that they suggest that we might want to use. I am so sorry that you're going through this. I want you to know that you do not deserve any of it. No one deserves to be afraid and hurt by the people who are supposed to love them. Please know that we're here to help in whatever way we can. What can I do that would be most helpful to you? When we actually do some of these things, it does make a difference. And these are some of the studies that actually show that. In one HMO, 67% of the 265 women who were referred for further IPV counseling actually did go and seek that counseling. They did speak with that IPV expert. In another study of 132 abused women, those who talked to a healthcare provider were almost 4 times as likely to use an IPV intervention. And those who used an IPV intervention were 2.6 more time, had a 2.6 more likely the odds of leaving their abusive relationship and reporting improved physical health and leaving safely. So in conclusion, IPV is a prevalent problem among that's associated with significant health problems. We should be talking to women about intimate partner violence, but how we talk actually matters. The process of change for women experiencing IPV can be gradual and it can be slow, and we need to understand that and be patient with that. The key components to moving towards change and safety are awareness, support, and self-empowerment. And as healthcare providers, or actually as anybody, as friends and family members, as community leaders, all of us, we can be positive influences to assisting the women with this process. These are some of the information for, and I looked up some of the ones in sort of your region as well. But again, the National Domestic Violence Hotline number is 1-800-799-SAFE. I want to thank you very much for your attention and would love to engage in some conversation and discussion about this topic with you.